Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
And I must say, I'm also a proud alumni of the Microsoft Corporation. I just have to share this anecdote with you. This is like just absolutely tickled to death to be here speaking to you today. I started my career at Microsoft as a systems engineer for all things interactive television in the mid-90s. I was a systems engineer in Tokyo for Microsoft, connecting 32 homes and fiber optic cables and experimenting with Microsoft's own interactive TV. And now I find myself coming back here with the Microsoft research working on the Xbox. And so it's really a harmonic convergence of everything that I've been doing to date, and it's just dawned on me. So I'm just really delighted to be here. So I'd like to talk to you about the challenges in measuring Parkinson's disease. But before I do that, I'm going to tell you a little bit about the Michael J. Fox Foundation. We're the world's largest nonprofit funder of Parkinson's disease research, and our mission is to help accelerate the development of therapies for Parkinson's disease and hopefully one day to help find a cure for the disease. It was founded by the actor Michael J. Fox in the year 2000, and we've spent a bit over $450 million in Parkinson's disease research. Our business model is one of urgency and accountability. 89 cents of every dollar is spent directly on Parkinson's disease research. And we work with industry. That's why I'm here. $100 million of that $450 million is spent on industry-led projects, and primarily partnering with biotechs and pharmaceutical companies. But since my introduction in September as the Director of Data Science, we're ready to work with high-tech companies. So we're interested. And so we want to work with you. Come to us with your ideas to partner and collaborate. Love to hear your ideas. So now on to the business of objective measures of Parkinson's disease and challenges and directions. A challenge. The standard measure of Parkinson's disease is what's called the Unified Parkinson's Disease Rating Scale, otherwise called the UPDRS in the industry. It has 4 sections. It's a survey that the neurologist gives to the Parkinson's disease patients. The non-motor aspects, the experiences of daily living. So have you been experiencing hallucinations? Are you depressed? Those types of categories of questions. Aspects of daily living, such as speech. Are you tossing and turning in bed? These things, the patients are required to kind of remember how they've been feeling to the neurologist. And there's a motor examination, which I'll get into in the next couple of slides. And finally, a survey on motor complications that ask things like time spent with dyskinesia. Dyskinesia is a symptom, a side effect of the drug levodopa, which is the gold standard therapy for Parkinson's disease. It is a disease in which the motor neurons in the brain, the dopamine neurons, are dying, and the neurotransmitter dopamine is beginning to fade off, and this is causing the Parkinson's disease patients to slowly decline in their capacity for self-initiated movement. So let me give you an example really quickly of what the motor, what the motor part of the UPDRS looks like. Is the video on? Hold on. go ahead and go ahead and play this. Oh, I don't think the audio is going through. But this is the standard get up and go test. And they're observing the patient walking, looking for arm swing, and they'll rate the patient's ability to walk from 1 to 5 or 1 to 4. And now this is a pull test. The neurologist is looking for how the patient recovers from this pull test. The number of steps they take will reflect a score from 0 to 4. Now you can imagine my previous boss changed neurologists. One who was a petite 125-pound neurologist to someone that weighed over 200 pounds. You can imagine what that rating, how that rating score could have changed. So the point of this is the challenge is it's not very objective. It's a survey. It's insensitive to changes under 1-year increments, right? So this is what makes the cost of delivering therapies to market for Parkinson's disease so expensive. And there's not enough discriminating power in these measures, these clinical measures, for where we could stratify the phenotypic subtypes of the disease. And this is where ambulatory mechanized measures are going to play a key role. And we've been working at this. I've been working at this for the past 10 years. In my previous role as the program manager and program director and manager of the Kinetics Foundation, we worked with the digital health group at Intel to take upper body motor test battery. We've taken components of the Purdue pegboard, a movement time, reaction time test in these 2 buttons, a trill test, a tremor watch was associated, and we had a test for voice. And this was an attempt to pull together what we knew about upper body PD motor symptoms and putting it into an objective device. And we ran a clinical trial of 50 patients over 6 months' time on this device. And at the same time, we funded a company called APDM. And this is Dr. Faye Horak out of OHSU, who's the scientific director of that company. And they've came out with a 6-sensor system to measure mobility for Parkinson's disease. And through the experimentation of the mobility device, they found sensitivity and specificity of the 4 best metrics for instrumented timed up and go. Now remember, instead of just having the neurologist watch someone walk up and down a hallway, now we have things like peak arm swing velocity, cadence, peak trunk rotation velocity, and average turning velocity. The turning seems to be the most specific, and it's hard to game. Anecdotally, I remember when Dr. Faye Horak first came out with these measures, she was very excited. She came to our office, and she strapped me up with the devices, and she made me do a timed up and go. And then she gave the same set of sensors to Andy Grove, who's also a Parkinson's disease patient, and made him go down the hallway and came back. And he saw that the time it took for him to come back to the chair was slower than mine. So he just claimed that he didn't understand the point of the test. So he said, I got to do it again. Faye kept saying, okay, but please, just walk normally. You're supposed to walk more. It's not a competition. He goes, I got it. So he goes, walks. But then his turning is something that he could not game because it requires balance. And so that was a very telltale sign that his cadence had increased. He reduced the time. He went faster than I did coming back to the chair. But we could see very clearly in the gyroscopic information that the turn did not improve. So I think this is really the value of these instrumented measures. And over here we have the stride time. So the coefficient of COV is the standard deviation over the mean of stride times for a 2-minute walk. And you could see that the variation is highly increased in Parkinson's disease patients, and stride time is longer. And it's primarily due to the fact that Parkinson's disease patients have a longer dwell time on their 2 feet in the middle of their gait. And that's also hypothesized that it makes them a larger risk for falling. Here's another very interesting metric by Horak and Mancini, that this is from a 30-second quiet stance. And you could clearly see, when compared to healthy controls, you begin to see a difference in much larger radii in controlling your center of mass in Parkinson's disease patients. And it keeps changing when they go on levodopa. It gets even larger. And when they're on the peak dosage of levodopa, you could see the quiet stand has gotten quite big. And it's hypothesized that this is also correlated to when they have bouts of dyskinesia. And then they go on deep brain stimulation. This is a therapy that counteracts the side effects of levodopa. It is having electrodes in the brain connected to a pacemaker that silences the neurons that are causing the uncontrollable motor movements that we call dyskinesia.
I'm sorry, quick question.
Yes?
I'm not as familiar with Parkinson's disease. Does Parkinson's disease always affect, long term I know it affects the entire body, but in early early symptoms, does it tend to affect the entire body, or can it or manifest in just a single limb, half of the body?
It's exactly right. It manifests differently in different people, and that's why we need these more sensitive measures. That's what we're trying to get at. We need to figure out what are the phenotypes. Currently there's this hypothesis that there are tremor-dominant Parkinson's disease patient and what's called posture instability and gait difficulty. But depending on what data set you look at, some of these subcategories hold and some don't. And we need to get more specific. And this is the hope of what we can achieve with body-worn sensors. Now, using the 2 instruments that I just showed you, the at-home device and then the mobility, we did a clinical trial at the San Francisco VA hospital where we had patients with the deep brain stimulators, and we blinded them and we changed the voltage randomly to see if supposedly if you lower the dosage, lower the voltage, that's the same as kind of akin to lowering the medication on the patient, right? At a much, much faster feedback rate. And lo and behold, it did hold. So this was very interesting. You see the UPDRS scores go down as the voltage is reduced, same with dexterity and mobility. So where do we take this? We're always asked by pharmaceutical companies, have these measures been validated? Has this become the standard? And it's very difficult because when you're trying to compare yourself to UPDRS, it's kind of akin to calibrating GPS against the sextant. I love getting the smiles from our physical therapists. They know what I'm talking about. So really, what we're trying to do is we want to stratify and figure out what are the subtypes of Parkinson's disease patients. And as many of you said before, it's time to take this stuff out of the lab and into the real world environment. So we are working and contracted with the Intel Corporation. We're developing a platform for wearable sensors. And we have a goal to instrument 1,000 Parkinson's disease patients by the end of this year. And currently, we're working with a system where the patient is, our current experimental paradigm is with a smartphone that's worn on the hip and a Pebble watch, and which we have programmed to sample at 50 hertz. And we'll be constantly taking in arm swing measures, and gait measures, and communicating via low-power Bluetooth to the smartphone. The smartphone has the accelerometer and gyroscope on persistently. And we're hoping to get, currently we're running a small clinical trial with 50 patients at Mount Sinai and Harvard University and in Tel Aviv to get at the different gait dynamics and also activities of daily living. It is an exercise in labeling the specific signals to actions of the patient. So the protocol is fairly detailed, where we're having them, sit, stand, lay down, walk, climb stairs, and we're videotaping them in the clinic and mapping the signals to the activity. And then we have the patients go and take the set of devices in the home and going through having a very detailed self-reported diary and what they do by the hour. And they do this for 48 hours and then come back to the clinic and do another set of motor. We put them through another motor test battery. And then we have another clinical trial. We should be done with this by next month. And the following month, we'll have a levodopa response trial where we'll actually try to see if the algorithm that we built in this one will be able to detect the changes from the response to levodopa. And if we were able to do that, we'll have our first version of the platform ready for research groups that want to quickly deploy wearable sensors for research by the middle of this summer.
So again, you said just 2 sensors, just the Pebble watch and the phone.
Yep, for now. But I want to stress to you that our intention is to be hardware agnostic, right? We're going to be characterizing what do the signals from accelerometers and gyros look like, and does where you wear them in the position of the body matter all that much? We're going to get smarter about it. Currently, we're having issues with battery life, which is no surprise. You have your gyroscope on, so we're trying to figure out the right optimization to make this happen.
Have you guys done any work with companies like Nike or Philips has an Active Link product where they're essentially activity monitors with multiple accelerometers, gyroscopes in them, and they've done their own work, at least from what I've read, in trying to determine, was I running, was I walking, was I bicycling without user input? Has there been any collaboration with commercial companies in terms of who have already been working in this space in some regard?
Actually, the watch that I'm wearing right now is called the Basis watch, and it's the first of its kind. It has an optic sensor in the back, So it's a heart rate monitor. It measures my skin temperature. It knows how much perspiration there is at any given time. They've produced algorithms. It knows when I'm walking, running, and riding a bicycle, which I think is pretty incredible. And then they have a really good algorithm that would just prove that it is 92% as accurate as a polysonograph. So I could go up on the web and I could show you later my sleep patterns, whether I'm in light sleep, deep sleep, or in REM sleep. And REM sleep disturbance is a big prodromal signal for Parkinson's disease. So we're hoping in the future we'll get the APIs for this device and be able to incorporate it into this platform. But in terms of the consumer, our intention is also, we don't want to reinvent the wheel. We want to be able to use consumer level devices, and it makes sense from a cost and a support standpoint. And so this is this is the level. So you can see on the scale, this is the macro level reporting. This is the pre-processed information, and up here is the raw data. Okay. For Parkinson's disease, it's going to be somewhere in this spectrum because we need to be able to pick up Parkinsonian tremor, which is anywhere from 3 to 7 hertz, right? In the current Fitbit realm, that's not available. They just pre-processed information to tell you the number of steps that you've taken and how long you've been walking. And that's all pre-processed, and it's very efficient. It doesn't take up much power. But then again, we're not sure whether this information is going to give us the data that we need. Now, long term, I could see the correlation. If your gait speed is slower as a Parkinsonian patient, it's going to reflect here. But it's going to take us a lot longer to figure out how well it correlates to those symptoms. So we're working at this level right now, and we're trying to get systems to work at this level. And in regards to how we're going to deploy, we intend to deploy this to our currently sponsored observational clinical trials. But also, we want to take another revolutionary step. And we're going to be launching something that's called Fox Insight, which is a patient registry. Think of it as a Patients Like Me site, where patients could come in, register. They could do an online version of the UPDRS, put their medical information there. And then as a part of the sign-up, they get to either get devices from us or download our app and get hooked into our network. And the benefits will be that for clinical trials, when we refer them to clinical trials in the future, right, we'll have the most well-characterized baseline of patients ever for pharmaceutical companies, right? We'll have a really accurate cohort, but also we'll be able to track patients across clinical trials because we'll be all wearing the same level of sensors. There's just a check box that says, what clinical trial have you been participating in?
That sounds like it'll, crowdsourced, being a part of your cure, actually taking a role in it could be very rewarding for individuals.
Absolutely. But not only that, they get a benefit out of it too, because we'll be presenting their information back to them that makes clinical sense, clinically relevant information. They'll get more insight into their own disease and be able to work with their neurologist to say, this is exactly how I've been doing. They won't have to go through the very difficult task of trying to articulate how they've been doing in the last 6 months, whether their medication's been working or not. Their doctors will have this information before they come into the office and say, okay, it looks like my REM sleep is going down, so we got to do something. So this is the paradigm. We're going to try to hit 1,000 patients by the end of this year, and we'll share our data. And please contribute with your ideas. We're really looking forward to working with you. Yes.
One minor suggestion or request is in your registry to collect information on pain. Because it's even in Parkinson's, we've seen studies that are showing really profound effects on physical or activity profiles using accelerometers.
Absolutely. But Parkinson's disease patients suffer from dystonia, in different parts of the body, and pain's a very important component of their well-being. So I think we do have that.
One question I had was, how much difficulty have you had in trying to get your device or your approach approved by the FDA? As it seems like you're trying to move this as an outcome measure for
Right.
trials.
So it's not making it a primary measure.
You're not.
You're not. We're not.
So
This is a patient registry. It's going to give them added information. My basis, this company is already kind of presenting this kind of information on the web today. Actually, I could show you. It's just a matter of how people use this data. I think it'll prove itself over time. At least that is the hope. And we'll gain some insights. Let's see. Hold on. Okay, so this is my basis. I'm going to show you my information. There we go. Okay, so this is me. Let's look for some interesting information here. I'll show you the level at which this is able to track me. All right, so let's see. The depressing part is you get to see how inactive I've been. Let me find a more rich experience period. Okay, so here's activity. Here I do some walking here. Wait, I'll find where I actually go bicycling. That's more interesting. Not there. It's been a very busy couple of weeks. Okay, I'm trying to justify my inactivity to you. So right now, right here, this is my average heart rate throughout the day. You can see how it goes up when I go bicycling. Okay. The number of steps I've taken, the average number of steps. This is the calories that have been expended in different parts of the day. My skin temperature and my perspiration. So you could see it's kind of interesting, how you could see how well the body regulates in a healthy person, relatively healthy person. So my body temperature is pretty consistent, but my perspiration keeps it under control when I go do some strenuous activity, right? But this is an autonomic symptom that goes awry in Parkinson's disease patients. So we'll be able to see that with this kind of device. These breed of devices that are coming out in the next 6 months. More interesting is I'll show you some data from sleep, which I think is very, very telling. Okay. This is a very bad sleep score, 32%. This is light, this is deep, and this is the amount of REM sleep that I've been getting. And so, REM is the garbage collection of the brain. So, you're thankfully, I've got 21%. They say in a healthy range, it's anywhere from 15 to 20%. So I feel happy about that, at least, even though it was very, very reduced sleep. So this is what the future holds, right? You know, right now, I mean, I think we all are agree that gait is a window into cognition. And now, you know, in the future, with these body-worn sensors, we'll be able to look into the autonomic functions of patients and see how it relates to your health. And what I hope where we could see technologies like Connect help is give us validation in the home to tell us, is what we're seeing in these sensors, what we think we're seeing in these sensors, actually happening? So, yes?
This is not related to the talk, this is just out of curiosity. I heard that in recent years there's accumulated evidence that Parkinson's disease starts from the body and not from the brain. Something about the Lewy bodies that are found, that were previously found in the area of the brain needed for the operations that are measured in Parkinson's disease, and now they actually find them in the body before they find them in the brain.
You're absolutely right. This is bioscientist by the name of Brock, and he has brought this hypothesis probably 7 years ago, which has gained a lot of popularity and consensus amongst the scientific community that Parkinson's disease may start in the gut and work its way up through the vagus nerve and finally into the brain. And there's statistical evidence that kind of supports that, where it's known that bouts of constipation is correlated to Parkinson's disease. You know, constipation, failure of hyposmia, the ability to smell, and sleep disturbance may be early indicators of the disease.
So you guys, you know, do you have any researchers that you support that look into that? Because it might be, you know, that, you know, a different concentration of
Absolutely.
stuff.
So we're, you know, in our observational clinical trials, we have one that's called the Parkinson's Progression Markers Initiative. Close to, it's about 700 patients in early state of the disease, and also patients who are high risk for Parkinson's disease are participating. We take their blood samples, cerebral spinal fluid, urine, MRI scans, dopamine transporter scans, and put them through the UPDRS and a number of cognitive test batteries at times 0, 3 months, 6 months, and 12 months, and then once a year thereafter for 5 years, hoping to see this kind of signal. And you know, it kind of highlights the challenge, really. This is why we're going after wearable sensors, because even with that amount of data, when you try to do even with that amount of data, it's still under 1 million data points, and that's hardly enough to do machine learning algorithms to find any kind of inference of what's going on. We're hoping that if we add, you know, wearable sensors, you know, just in 4 hours we get 5 million data points. And so if we were hoping if we add these wearable sensors to those patients with this rich biological data, we'll finally have the discriminatory power to be able to pinpoint how the disease is progressing.
High risk. Genetics, is that?
There's a genetics cohort. Things like there's LRRK2. It's a gene that's prevalent in the Ashkenazi Jewish population, in the northern African Berber population. they're part of one of the cohorts in our observational studies, so we're looking at that. Yes?
Have you thought about, in addition to kind of just tracking patients, but using those accelerometers to actually look at kind of effectiveness of L-DOPA treatment in some of these patients? Because I know over time, as you continue to treat with L-DOPA, there becomes a point where L-DOPA doesn't really provide the same benefit. So could you use that, the wearable sensor system to kind of track when maybe a patient is starting to plateau? Or in the other hand, there's certain patients that just don't respond, period, to giving L-DOPA. So if, you know, instead of giving somebody L-DOPA for a month, if you could just give it to them and then monitor their progress, and then over a period of 3-4 days, you could kind of see if there is a response.
Oh,
or
absolutely.
not.
I mean, I think that's one of the real immediate benefits of this system, right? Where, well, one of what the currently kind of the acid test to see whether someone actually has Parkinson's disease versus, you know, multiple system atrophy is the levodopa challenge. So if they respond to levodopa, then it's a pretty good indication, you know, having bradykinesia, rigidity, and a tremor. If you have those 3 symptoms and you respond to levodopa, then you're classified as a Parkinson's disease patient. And the key to improving one's quality of life has everything to do with proper timing of levodopa. So, you know, you could have a dosage, a recommended dosage per day of levodopa, but how you administer throughout the day makes every bit of difference in the world. You know, making sure you don't take it too close to when you're eating some meal that's high in protein, for instance, and just making sure that, you know, you try to do your best to biomimic the release of dopamine in your body as a response to levodopa as much as you can. And right now it's an art among neurologists. So hopefully with this kind of system that you wear all the time, that's invisible to the public, is something that will really help patients.
Yeah, we actually talked to a surgeon who's doing DBS, deep brain stimulation, and he said the modus operandi currently that patients come every 3 months to his lab, and he tunes the amount of voltage that the electrons get. And he said that it's the goal would actually be some dynamic and automatic tuning of the voltage along the day and over several days, which will increase the quality of life tremendously.
Well, like, continuing this line of questions, so is it currently focusing just on collecting data? Also, are you looking into the closed control loop scenario in which, you know, maybe, for example, you were talking about when to take the L-DOPA. So would part of the study allow for someone to say, oh, I think that, you know, if you were just walking, that's a good time to take the next dosage or something like that. So doing something more for closed control loop.
Right. I think that'll be a feature in the future, but to that point, I think when we provide this information in a dashboard to patients, they'll be able to work with their neurologists to figure that out much better than they have been able to do so before. But you know, if we could, you know, figure out the algorithm of how to, you know, what is the ultimate dosage depending on the type of patient, and that's something that we are going after as well. So look forward to it. We'll be making the data available. Take down our data and tell us what you see. Thank you very much.